Next, I would like to invite Professor Untitled, Professor of Neonatal Neurology at Imperial College London and the Chief Investigator of the PREVENT study, to speak about the topic, Weak Baby in the Womb, Why Cooling is Not a Solution. Welcome, Dr. Sudhin.
Thank you, Pallavi. I was going to say good afternoon to all of you joining from India and good morning to those from UK. But I see people from a lot of different countries have joined, including Professor Alistair Gunn from New Zealand. So welcome to all of you. And especially warm welcome to the parents. You know, a lot of parents are going to join this session. എല്ലാവർക്കും സ്വാഗതം ഈ symposium. So I'm going to talk about why and how we came around doing the PREVENT study. What is so different about the babies with HIE, what we call as hypoxic ischemic encephalopathy in the settings, or birth asphyxia-related brain injury. Now, this is the traditional definition of brain injury or birth-related brain injury. Something suddenly happens at the time of around birth, a lack of oxygen and blood flow to the baby's brain, and then the baby gets hypoxic injury, ischemic injury. At least that's what we think. So this causes brain damage to the baby. So typically mothers will say everything was going on, all the natal checkups so fine. And then something happened during labor, usually something major like cord prolapse, subduction, and so on. Now, is that a big issue? Now, if you are a postgraduate student at IMCH and Calicut, probably, the vast majority of women giving birth in the centers do have normal pregnancies and normal healthy babies. So vast majority, 98% will be fine. It's only 2% are affected. It's only 2%, but that's actually 2 families, 2 lives. And then when you look on a global scale, that's even bigger. So in the next hour, when I'm doing this lecture, 300 more babies would have born and will die or have life-sustaining brain injury, including disabilities and epilepsy. And if you compare the global burden of encephalopathy, it's not something you want to compete to. But if you look at the global deaths that has happened from the COVID pandemic in the past year, it's around 35 lakhs. That's the same number of babies with encephalopathy being born every year. But this has gone as an unrecognized pandemic for decades. So once the baby is born, what can we do about this? So a lot of work has been done on this area from high-income countries. So if you cool, mainly from Professor Alistair Gunn, who has kindly joined us from New Zealand, who was one of the first people to show cooling. If you cool these babies soon after birth, within few hours of birth, you can reduce this brain injury. So 3 big randomized controlled trials, large whole body cooling trial led by Sita Shankar in the US, and the CoolCap trial from New Zealand multicentric study involving centers in the US as well. And the TOBY trial, mainly led by investigators at Imperial College London. They all have shown that if you cool these babies soon after birth, you can reduce death and disability. So that is very reassuring. So based on this, a lot of people in India and other LMICs now, developing countries now, routinely cool these babies. But we recently reported, we examined if cooling is safe and effective in Indian settings and other developing countries. And unfortunately, it was not. So this is the key result from the Helix trial. This is the largest randomized control trial of whole body cooling conducted anywhere in the world, and the first phase 3 trial from low and middle income countries, recruiting over 408 babies from India, Sri Lanka, and Bangladesh. So cooling did not reduce death or disability following neonatal encephalopathy, but in fact, it increased mortality at 18 months. It also did not reduce severe disability or did not reduce microcephaly in these babies. So cooling clearly did not work. And when we looked at the short-term outcomes, this was even shocking. These babies were literally bleeding to death. They had more gastric bleeding, more pulmonary hemorrhage, prolonged coagulation, thrombocytopenia, and so on. So these babies were, like I said, bleeding to death. Now, why is that? That is a big shock. Why is that? Why is it so different about our babies? This study were conducted in tertiary intensive care units and used the same cooling device we used in high-income countries. So the only possible explanation is that the populations were different. So what is so different about the population? Of course, we can only speculate. But if you look at the population, the Helix trial, the incidence of perinatal sentinel events, the one I was talking about, the abortion, collapse, and so on, that is very low. Less than 13% had those kind of sentinel events. And of course, the birth rate of our babies are at least half a kilo lower than the high-income countries. And one of the other things we noted that a lot of babies were having seizures at the time of randomization. Almost 25% have seizures. The seizures typically occurs about 6 to 12 hours after your brain injury. So something odd is happening. No acute sentinel events and seizures are happening earlier on. So maybe because the cooling was only if you give it in a short window period of 6 hours, maybe that window period is gone by the time these babies are born. But can we actually prove it? Is there any biological evidence? We think there is. So we looked at the expression of genes in babies with this kind of brain injury in high-income countries and also in India and other LMICs. So when I say gene expression, that has nothing to do with the genes. It's how your body reacts to different exogenous stimuli like hypoxia, infection, and so on. So what we found was a marked difference in the underlying mechanisms of brain injury. So in high-income countries, it was mainly the acute hypoxic pathways which were involved. But in LMICs, there's a different pathway called ferroptosis. And the direction of the change in these pathways was diametrically opposite. It was indicating the brain injury was occurring several hours before birth in LMICs. And that might explain why cooling did not work. Well, that's all fine, but what can we do apart from stopping cooling? There cannot be any excuse for continued cooling in Indian public sector hospitals for sure. But how can we prevent this from happening in the first place? And that's how we came about with this PREVENT study. Now, these are the key elements like Professor Chagaran and Dr. Mini mentioned. We got 4 elements, key elements in the PREVENT study. One is empowering birth companions and respectful maternal care. Using an electronic labor record to monitor the labor progress of these women because labor partograms are time consuming and it's hardly ever filled in real time. Using a graphic Doppler, so like Prof. Shakaran said, instead of just listening to your heart rate, where it's 130, 140, you see a trace of this heart rate, how it's changing without using a CTG. And the fourth and final element is once the baby is born, we can't turn the clock back, but we can prevent ongoing injury by providing therapeutic pneumothermia and other optimal supportive care. So these are the key elements of the PREVENT study. And I'll briefly take you through some of the baseline data. We're not done the full analysis yet, but these are some of the key data from the study so far. So altogether, we recruited over 40,000 women now. The incidence of encephalopathy, as we knew, was 10 times higher than in high-income countries, bit lower in Calicut Medical College compared to the other sites in Karnataka. But the surprising thing was that vast majority of these women had more than 4 antenatal visits that are recommended by WHO. So, the median was 7 visits, 6 to 9 was IQR. So these women are regularly coming to antenatal clinics. The incidence of anemia is only 14% the ones who had encephalopathy. There are not many comorbidities going on. Diabetes is not that high, not too much hypertension, but they're still getting hypoxic ischemic encephalopathy in the babies. And surprisingly, these women are coming for delivery much earlier on. Many of them are coming even before the onset of labor or in latent period. So 75% of them were admitted to hospital even before the onset of, before they started active labor. So that's again quite worrying. It just indicates that just by improving, of course, we should improve neonatal care and we should encourage women to deliver in hospital, but that alone is not sufficient. That alone is not going to reduce brain injury. And surprisingly, in exactly what we found in Helix trial as well, the incidence of intra-partum sentinel events was very low. Only 4% of the babies with encephalopathy had intra-partum sentinel events. Now, what happens to these babies with intra-partum sentinel events? That is quite reassuring. So if you have a major event like hot collapse abruption, the chance of death is only 1%. Vast majority are surviving and doing well, completely normal. Encephalopathy was around 12% in that group. So this is very much in par with high-income countries. And I know for a fact, I'm sure Professor Shagaran might be holding some Guinness World Record for the fastest cesarean. So these are highly skilled people in tertiary medical colleges in South India we're talking about. So when a catastrophe happens, we have facilities that a prompt action is taken and the baby is saved. Now, when we had the first meeting 2 years back now, before the COVID pandemic, one concern was about using this new WHO labor care guide. So there was a lot of discussions around this, because in the new WHO labor care guide, the old action and alert lines are gone. And this is based on a large study funded by the Gates Foundation and conducted in Africa on 9,995 women, where they found that the duration of labor, duration of active stage of labor, had no relation with the outcome of babies. So here in red, you can see the babies who had adverse outcomes, and the black lines or dark gray lines are the ones with normal outcomes. So the duration you can see absolutely had no relation. So following this, so what you're seeing here is on the y-axis is the cervical dilatation. So active labor, we now consider more than 5 centimeters as active labor. And on x-axis, you're seeing time to delivery from 0 to 18 hours. So many women had deliveries lasting up to 18 hours, but still had a normal, healthy baby. So following this study, WHO made a major decision to update the partogram and develop this new labor care guide. Then, of course, this is based on a study from Africa, and clinicians, colleagues in India were quite rightly worried. Is this going to increase adverse outcomes? Can we wait that long in active labor? We don't know as yet, but I can show you some pilot data. It's only 1 month data that we have using. So we have been collecting this data using our electronic labor care guide, or ELCG, which is based on the WHO partogram. So this is a small pilot study on 2,178 women, 38 babies with adverse outcomes. But what we see is exactly very similar to what WHO BOLD study showed in Africa. The duration of labor does not appear to have a relation with neonatal adverse outcomes. So most adverse outcomes are happening. So the red lines are again babies with adverse outcomes. Black ones are the ones with a good outcome. Many of them were delivering within a couple of hours, but still had adverse outcomes. Hardly any labor was going more than few hours. In a way, this was reassuring that it might be okay to use WHO labor care guide, because I, like the obstetric colleagues, India was also skeptical because the WHO change in protocol was not based on rigorous randomized control trial, which is the gold standard evidence for a new intervention. But there is very good observational studies to suggest that it's inappropriate that we are mandating labor should be completed within such a short time, or the traditional 1 centimeter per hour of cervical dilatation. But on the other hand, this data is also a bit surprising, because the labor duration in these sites is too short. Within hours, or these women are delivering. So why is that? We looked at the best thing is oxytocin. Are we using oxytocin? So only 10% of these women were getting oxytocin. So we collected this data over 1 year, mainly from the medical records. So that was a bit surprising. So then we thought, this is a picture from the epic Mahabharata. If Kijaka has died, it must be Bhima who killed him, because not many people can kill Kijaka. Then we thought we need to look into more detail, and then we appointed intra-partum nurses, intra-partum fetal monitoring nurses, to observe what is happening in the labor room around the clock. So they were not looking at the medical notes, they were directly saying what is happening, how much of oxytocin is being used. So then we found that the actual incidence of oxytocin augmentation was actually much higher. Although it started to come down. Once we recognized there is an issue, it started to come down. Because the trained doctors are so busy in doing the work, there's hardly any time to document. But of course, it is important to document so that we can make sure it's given only for appropriate indications. Now, why is oxytocin so bad? So this is a systematic review we published recently. It suggests that these are not randomized controlled trials, mostly before and after, or RCTs done for other indications, but it does look like oxytocin increases the risk of neonatal encephalopathy. So that's not a good thing to overuse. There might be some rare indications we should be using oxytocin, but not to this extent. And that's especially if we need to use, we should use it by infusion pumps. So these are the key elements of the Prevent Care bundle as we discussed. But one big element, like Professor Hagen alluded to, is this issue of research, academic capacity building at those sites. And I think this is extremely important, because Prevent study will finish in 3 or 4 years and that'll be gone. But this research capacity building, the people who do PhDs, fellowships, they will remain there, and then they will continue to contribute to the further improvement of patient care in those settings, and contribute to the scientific advances. So this is one big part of the Prevent study. So to summarize, these are my key take-home messages. So burden of encephalopathy is 10 times higher than the UK, we knew it. But vast majority of these women are having regular antenatal visits. And vast majority are coming very early to hospital before the onset of labor even. And very few are associated with acute sentinel events. And reassuringly, we have excellent outcomes even after sentinel events, which is very good. We do need to improve on our oxytocin augmentation and how we document that more accurately. And we also need to improve on women spending time outside the labor room during active labor. And I'm so pleased that Professor Mini has really taken on the lead on this and having monthly meetings. So this can be sorted out only if there is involvement from the highest levels. So HODs of obstetrics and pediatrics, along with the medical superintendent, are having monthly meetings to look at this data and to make sure these are addressed on a regular basis. And I'm sure we will be doing the same thing in Bangalore and Hubli as well. I'm just going to, I put a spoiler alert here. Vaishak is going to talk about this. One other surprising thing we found was a high mortality, up to 20% mortality in babies with mild encephalopathy in these settings. Babies with mild HI should not die. The mortality is less than 1% in the UK, and it's 50 times high in these settings, and partly it's due to hypothermia, but Vaishak will talk about this more. Now, this is a big team who are involved. I won't go through the names of even the big collaborators because there are too many, but we are all working towards a common goal to improve the life of mothers and babies. And we can do it only if you all work together, not just the medical or nursing professionals, but including the people, including the cleaners and security people and so on. This is an all too familiar quote you might have seen when President Kennedy visited NASA for the first time in '62. So he found, it was quite late in the evening, and he found a housekeeper walking with a broom. And then he asked him, "What are you doing here at this time?" And then he said, "I'm helping to put a man on the moon." So that's the aim we should have. Everyone, including security people, the cleaners, PG students, nurses, and of course, the senior people, a common aim of reducing brain injury in babies. Now, before I stop, I just want to do a small poll. So these are the 4 elements of our care bundle, and I've given 2 more elements if you want to. But I just want you to guess, which of these elements do you think is most likely to reduce brain injury in babies? Harini, do you mind just doing the poll? So these elements are the companion respectful care, that's intelligent auscultation, graphic Doppler. This is a very, very good thing to do, because even in the UK, we are not doing this. We are either doing continuous CTG, which is not good, which will increase the cesarean, or just auscultation by stethoscope, which is what midwives do. So this is a very novel thing to have a graphic Doppler, very advanced technology. Electronic labor monitoring, again, it's very good to monitor that. And my favorite, of course, is brain-oriented care with therapeutic nomothermia, real-time EEG, advanced MR imaging, and so on. So of these, what do you think is most likely to reduce brain injury? Had any poll complete?
Yeah, only 80 of them out of 130 has answered. Let's wait for 1 more minute.
Okay.
Everyone can type the answers on the screen. I hope everyone is getting the poll on the screen. I have some answers in the chat box too.
Okay, let's look at the results, Harini.
Yeah.
So I'll read out the results. So birth companion and respectful care, 5%. Intermittent auscultation, 13%. Electronic labor monitoring, 7%. Brain-oriented care and nomothermia, 4%. All of the above, 71%. None of them.
Thank you, Dr. Sudhin. We have a few questions in the chat. Should we take it now, or can we have it during the question and answer session?
Later on, later.
Yeah.
If Farul is there, you can.
No, Prof. Farul has not been able to join yet. We had the medical superintendent who joined, but now I think he got disconnected.
Okay, in that case, we can take questions. Yeah.
Yeah. So we have a question from Professor Alistair Gunn. So Professor Alistair, would you like to come in and discuss the questions, or shall I read it out?
Thank you very much. I had only 2 questions about this very interesting talk. The first is, since you have electronic monitoring, will you measure deceleration area? There's very good evidence from Alison Cahill and a couple of other groups that the single best indicator of risk of acidosis is deceleration area, and the combination of deceleration area and interocclusion or interdeceleration tachycardia predict adverse neonatal outcomes.
We could do that, Alistair. Unfortunately, Profile has not joined yet. I think this Profile is best to. We are downloading this data into a software, into a computer, and keeping it. So that's an analysis we could do. Yeah, it should be possible.
So thank you. It's their data, both retrospective and prospective, say that those 2 parameters are better than any of the sort of the classical interpretation. The loss of variability, the shape of the heart rate, all of that's garbage. It's the deceleration is the best indicator of hypoxia. And I think tachycardia is an indicator of fetal catecholamine release, fetal stress, which explains its link with that neonatal outcome. The second thing, which you alluded to in a tantalizing way, was maternal pyrexia. In case control studies, there's a 4-fold increase in risk of needle encephalopathy with any increase in maternal temperature. So I wondered whether that would, first of all, whether we should monitor it, and secondly, whether that might actually be a useful target.
Yes, we are collecting hourly maternal temperature data in the epartogram. Yeah, I think, yeah, we'll make sure it's all
Dr. Sudhan, even
rooms.
sorry, Dr. Sudhan, even decelerations, fetal heart rate deceleration is also being monitored as a part of FHR. So yes, FHR.
It's not the presence; it's the total area of the deceleration, which is the depth and the duration of the deceleration. Shallow decelerations are nothing. The unborn child can tolerate a shallow deceleration all day and all night without suffering injury. It's the deep recurrent decelerations that are a concern.
Yeah, depth we are not measuring right now, Prof. Alistair. We have temperature monitoring and the presence of decelerations.
Yeah. Thank you, Alistair. That's very insightful as always. Yeah. Alistair, do you want to? Do you mind just repeating?
The issue is there's now actually quite compelling evidence that the thing that best predicts acidosis at birth is the total area of decelerations over time. Alison Cahill and several others have published potential thresholds. We've shown this in the fetal sheep. The other important parameter which predicts neonatal outcome is the presence of tachycardia and the duration of tachycardia. So I was wondering whether, since you're doing an electronic record, you would be able to either, at very least, measure it and see if you can replicate Alison's data in India, or whether it would be better to, whether you think there's enough data to even target it as an intervention. My feeling is that decelerations alone are not enough, that the unborn child can tolerate shallow decelerations basically forever, or at least as long as the mum can tolerate labor. So it's the deeper, longer decelerations that are the issue.
Okay, the question, I hope you can hear me. The question needs a couple of hours of discussion, so I might just put it briefly. The predictive value is actually on a number of items on the CTG. Number one is the deceleration area, but this is a progressive picture, so the deceleration, when it becomes more and more hypoxic, the deceleration depth and the duration keeps on increasing. Then the baseline rate also starts increasing at the same time, and finally the variability gets reduced. What is not captured properly, not studied so far, is the interdeceleration interval. So as you correctly say, that the deceleration area may not be the only predictive area. It might just indicate a response of the fetus, but how long is it in the baseline? Because the baseline, if it is spending less and less time, then it becomes more acidotic. And unfortunately, by just doing a CTG or by doing a Doppler graphic display, we won't be able to predict it, because this has to be studied chronologically. So the only way we can study these various components, that is the increase in depth and duration of deceleration, the rise in the baseline rate, the reduction in variability, which are predictors, can be only by machine learning. So there are a number of programs which are being postulated and run, one in Galway, one in Oxford. There's one from Imperial itself called the GRACE program, which is starting. So we'll need some machine learning process to really identify which baby is going to run into trouble if you're going to take this parameter. But for the time being, only thing we know in this particular study we know is actually to identify the fetus which are going to be in trouble. So if we get accelerations at the beginning, then we can monitor them intermittently. And when the deceleration starts, then they have to transfer them to a continuous monitoring or continuously monitor for 2 or 3 repeated contractions. So it's an important area, but it needs further study. So far, deceleration area has been highlighted and the rise in baseline rate, but there are more important components like interdeceleration, interval and reduction and variability. Thank you.
Can I say there's a limitation to interdeceleration duration. The problem is that the ability to recover depends on the fetus, not just on the placenta. So we have shown in the fetal sheep that even very widely separated decelerations every 5 minutes will still induce fetus if you're dealing with a spontaneously growth restricted fetus. So the status of the fetus is just as important as what we record.
Yeah, that might be the case, but that has to be studied, Alistair. The the lamb or sheep model will give some idea, but that has to be extrapolated and studied in the human fetuses, because we are dealing with not a standard fetus. We are looking at growth restricted fetuses, big babies, different other conditions like infection, etc. So the answer to the query is not easily answered. So we had to study at least 150, 200,000 cases. And there's a multi-center approach by machine learning to put everything into the same equation and see what will be the final outcome. But by visual estimation, it's going to be extremely difficult because of the very same thing you're mentioning, because the interdeceleration interval may not be the only answer. But if it is, but in general terms, if there is a gradual increase in the baseline rate, increase in depth and duration, and shortening of the interdeceleration interval, that's very indicative in the human fetus.
Thanks. So the other question, I don't know if we have time, but if we did, was about maternal pyrexia.
Yeah.
Maternal pyrexia is associated with a roughly 4-fold increase in the risk of neonatal encephalopathy in case control studies.
Yeah.
Epidemiologically, it's difficult to study because there's too little encephalopathy and too many cases. But I wondered whether that was something that could be a target.
Well, I mean, as we know that the temperature itself, even without isolating infection, can bring about the increase in neonatal encephalopathy as well as cerebral palsy. So the temperature itself is a problem. But on top of that, if there is infection, then we know there are circulating interleukins and tumor necrosing factors and so on. And Swedish groups have demonstrated on animal models that if you expose fetus to hypoxia and infuse saline as well as another group with lipopolysaccharides, the destruction area of the brain is much greater. So I think the temperature has 2 connotations. One is temperature itself, one is also associated infection and circulating factors which can cause damage. Now in this particular study, we are not really going into that. We are recording the temperature, but we will identify the things. So the outcome was poor in the neonate, whether there were any additional contributory factors like the temperature, or whether it's hypoxia or both together. So we can identify that. That needs some group analysis. So I think the recordings are done. So it'll be left to the group to really look at whether there's 1, 2, or combination which has caused the problem.
Any other questions, Pallavi?
No, we don't have it.